What is HIV and AIDS? How can HIV be transmitted, and how can HIV infection be prevented? Hello and welcome. I'm your host, Dr. Mtombeni, and signing with us is Trifosa Nzwelengwe. On Vital Signs, we'll focus on HIV and AIDS. On the 1st of December, the world commemorates World AIDS Day 2022 under the theme Equalize. The Equalize slogan is a call to action, a call to adopt the proven practical actions that will help end AIDS. But first, coming up on the program, the Johannesburg Health District is hosting a build-up towards World AIDS Day commemorations at the Fundisa Disability Center in Orange Farm. We'll cross live to producer Wandile Mfukeng about the objective of the event and also highlight some of the challenges that people living with HIV and disabilities face. We'll speak to Deputy CEO of the Aurum Institute South Africa about HIV and AIDS, as well as a technical specialist at Right to Care about the challenges that people living with HIV face. We'll speak to Director of HIV and STI Prevention Strategies at the National Department of Health about South Africa's HIV Prevention Strategies. And lastly, we'll speak to TB-proof MDR TB survivor as well as activists about World's Day event that will be hosted tomorrow at the Desmond Tutu Hall in Khayelitsha, Cape Town. Of course, we know that you can get in touch with us if you would like to be on the show. Just give us a call. The number will be on your screen right now, and you can use that call line to call us in and give your opinion or comment on what we're discussing today. Alternatively, you can also catch us on our social media on Twitter at SABC Vital Signs and SABC Vital Signs on Facebook. The show continues after this ad break. Welcome back to Vital Signs, where today we commemorate, and of course on the eve of World AIDS Day. Now, each year on the 1st of December, the world commemorates World AIDS Day. People around the world unite and show support for people living with HIV and also remember those who have died from AIDS-related illnesses. The Johannesburg Health District is hosting a build-up event towards World AIDS Day at the Fundisa Disability Center in Orange Farm. Now, the objective of the event is to strengthen and disseminate World AIDS Day messages and, of course, teach the community about HIV PrEP initiatives and highlight some of the challenges that people living with HIV and disabilities face. We cross live now to Wandile Mfukeng, who's our producer, and he's going to give us more.
Very good morning to you, Dr. Mtombeni, and the viewers of Vital Signs. Indeed, we are coming live to you from the Orange Farm. Specifically, we are at a Joburg Center, or rather the Fundi Center for Disability. They are together with the Johannesburg Health District. They've come up with a build-up event towards World AIDS Day. And currently, they have stalls, or rather testing stations, encouraging a lot of people in the streets to come and know their status, or rather check for HIV. But joining me right now, we have the center manager for Fundi Disabilities, who will be talking to us about the event and the importance of tomorrow's day and why we are here. Mama Selina, thank you so much for your time. Could you just kindly talk to us about the event or the importance of tomorrow's event and why are we here today?
Greetings. Lebitso la ka ke Selina Mbatha, ke mo Orange Farm under organization e bitswang Fundisa Multipurpose Skill Center for Disability. Re mona na Orange Farm Skill Center as re tsa awareness of persons of disability mo re tlo hlokomisang batho hore as ka tsela o sane e le di1 re tlo bana le HIV and AIDS awareness ya rona re tlo iketekang, so re tlo bontsha batho re ba rute hore le bona ke batho, le bona ba ka hlaelwa ke anything e ka ba etsahalang. Disability ha so re hakalo ke motho e le reng a ha tsebe ka ke tsa anything, but hona le ba bang ba di physical challenge, ba bang bana le di different kind, but ntwe ke tseba gore le bona ke batho o tshwana le rona ene ba hloka gore ba testiwe le bona hobane ba phela ho bana le moya mo maphelong a bona. Jwale le gone jwale ka re le batho re phela mo lefatsheng re tshwana le bona, hona different gore fela e mo le mona le challenge ya hae. So letsatsi la usane ka mo re tlo be re tiketa wellness e ka usane e le di1, so re kopa gore batho ba understand le bona ba ba acknowledge ban le bona ba hloka lerato ba hloka atamelwa ba tshwana le mang kapa mang ke batho be le reng ba hloka fela gore le ba atamele le bue le bona le utlwe ditlhoko tsa bona keng hakalo so ntwe nka itse gore bana ditlhoko tse ngata haholo ba bona ka re bona ba neglected bana ho shejwe fela hangata youth able le bana le basadi empa le bona ho ntse bona le tlhokomezo maphelong a bona so as ba tshwana le rona ba phila ba hloka gore rona re ba tshetse ka tsela e makatsang ke a leboha.
That was Mam Selina, the manager, center manager for Fundi Disability. Right now, I'm quickly introducing another special guest from the department who will be talking to us about this auspicious occasion. This is Mam Kanyisile. Thank you so much for your time. Could you just kindly tell us about today's event, or rather even tomorrow's event? What can people expect?
Okay, thanks so much. I'm Kansile Mabaso, responsible for the clinical program manager, NPOs for HTS and key pops. Today, the event is more about, our theme is re-engaging, integrate to end HIV. And the main focus is we are celebrating and commemorating HIV/AIDS Day. The main aim is to look at our successes, where we did well with HIV management, where people are living positively with their status and now they are virally suppressed, people are going back to work, but also looking at the gaps. That's why today we are joining Ifundisa, because we identify that is a gap, because we are not focusing on disabled people and their sexual being and their families. So we need to also understand their language when we do counseling, make sure they are properly counseled and they receive the services that they're supposed to receive. And also learn the lesson learned that we have identified. The psychosocial, we might be dealing with HIV only, but when we counsel my individuals, there are psychosocial issues that we need to also look at, because some of them they are HIV positive, they want to come and do the testing, but our facility user friendly, whereby if they are disabled, are they ramps so that they come and access our services. Hence, we've got our NPOs that are doing the services at community so that we can reach out to communities that are out there. But through involving all the sectors, disabled, the faith-based, the PLHIV, and the PWIT, because we are also focusing on PWIT, where it's people who are using drugs. They are human beings, and there are issues that are making them to use drugs. So we've got programs like PWIT, whereby we've got our DSP, which are our district supporting partners that are giving services to those people who are injecting and using drugs. But they also need HIV testing, because using those needles, they are transmitting HIV. So they supply them with health information and making sure they use needles are neat. And most of them with the good successes that we have learned, the lesson that we have learned, which as we engage them, we understand their psychosocial issues, they test, and some test negative, and they go back, we link them back to their family. So the main aim is to re-engage everyone, all the sector, integrate our services, and give a comprehensive service.
Kanye, thank you so much for your time. I think this is where we can leave it. We would like to encourage the community of Orange Farm to come through in their numbers to get tested and to get all the knowledge that they need to know regarding HIV and AIDS, and also with people who are living with disabilities as to how they can also be included in these HIV and AIDS discussions. So back to you in studio for now.
Thank you very much, Wandile. That was our producer, Wandile Mfukeng, and he has just crossed live, and we'll cross back to him live a little bit later on. After the break, we'll speak to Dr. Ntombi Mjali, the Deputy CEO of the Aurum Institute South Africa, about HIV and AIDS. Stay with us. Welcome back to Vital Signs. Now, HIV is a human immunodeficiency virus which can lead to acquired immune deficiency syndrome, or AIDS. Now, HIV destroys blood cells called CD4 cells, which help your body fight diseases. This means that HIV compromises your immune system and stops your body from fighting diseases. On this segment, of course, we'll give you a basic understanding and some basic information about HIV, such as how it's transmitted, how you can prevent it, and of course, how you should be going out there and getting tested. And we're going to do this through our special guest, Ntombi Ntombifikile Mtshali, and that is Dr. Ntombifikile Mtshali, the Deputy CEO of the Aurum Institute in South Africa. Thank you so much for joining us, Doc.
Thank you. Thank you for having me, and good morning to your viewers.
Lovely. So let's jump into it. It's still a very important question to ask, but this HIV and this AIDS, how does one get it?
As you've mentioned, HIV is transmitted through body contact. So usually sexual contact, and this is generally still a vaginal or anal penetration. But also we know, and this is when you're using, you're having unprotected sex without a condom, or maybe if you're not taking any preventative treatment. But also we know that people that are injecting drugs also are at high risk, and also people who are in the medical sector or who are likely to get needle prick injuries during the course of their work. But predominantly, it's still sexually transmitted as a common modality.
Now, you've mentioned that bodily fluids is something that would end up giving the spread of HIV. Tell us what kind of body fluids. I know you've mentioned sexual contact, but does that include spit? Does that include, tears and things such as that?
So body fluids, I think let's keep it at the sexual intercourse because that's the highest rate. We know that the virus in tears or the virus in spit it would be very low. So it's very unlikely that you can transmit HIV through that. I think you will have to have a lot of the fluid, but definitely the sexual intercourse because of the rigorous nature of it and also the exchange of those body fluids.
Now, a lot of the time patients would, or just the everyday person at home would always wonder about signs and symptoms and things that they need to look out for if they suspect that they might have HIV infection. Do we have these in this infection?
So I think you made a good distinction by talking about HIV being a virus, which is a human immunodeficiency virus, which does attack the cells of the body, which doesn't allow it to fight. And if it's left untreated, we know that HIV can then lead to AIDS, which is the acquired immunodeficiency syndrome. And those are two different elements. So we know that for HIV, certainly if we pick it up early, and this is why we also encourage patients or people to test and test regularly so that they know their HIV status. The signs and symptoms are generally when we start having when the immune system is so compromised that your body is not able to fight the disease. So we get what we call opportunistic infections, such as TB, which is, we can speak about TB at another stage, but we know the symptoms of TB is productive cough for a duration of 2 weeks, for more than 2 weeks, night sweats, what we call constitutional symptoms, night sweats, loss of weight, loss of appetite, and other, related to those. So the only time that we see, the symptoms of HIV is when people are already having the opportunistic infection. I think that's very important. And we know that most people are walking around, if you are controlled, if you've been tested and you start treatment early, we will not be able to see symptoms or signs of HIV disease if you're on treatment and you're still at the very early stages. So I think that's also very important to note that distinction.
We've got Lolly from the Northwest on the line. Good day, Lolly.
Yes, hello, how are you?
Good, sir. How are you?
Yes, I'm fine. Yes, I'm taking medication.
Yeah, Papa.
From 2008. Now it's like I've been really infected again. I'm starting to get sick now. So I wonder, because I'm going to the clinic, but I just saw your numbers. I want to ask some questions.
Okay. By medication, I'm assuming you mean your HIV medication, your ARVs?
Yes.
Okay. And then importantly, you said that you're starting to get sick. Have you been to the clinic recently?
Yes, it's just that it's only, they say my viral load is high.
Mm-hmm.
Now I'm asking what will happen next now.
All right, lovely. We'll ask the doctor this question and we'll get back to you. Just listen through the TV, okay, Papa?
Yeah.
All right, thank you. So that's Lolo from the Northwest Doc, and he's communicating that he knows that he is HIV positive, has been taking treatment for quite some time now, but is starting to get sick. Went to the clinic, and the big issue is that they're saying that his viral load is high. So can you explain how Lolo or many other people in this country could find themselves taking their medication but end up having high viral loads or finding that they're getting sicker and that the medication isn't working?
So the first question that I would want to ask from Lolly, and thank you for the question, is how is he taking his treatment? We know that patients generally, they can say they've got the treatment, but perhaps they're not taking it correctly. So the important step is establishing whether the treatment is being taken correctly at the right time, at the same time every day. If it's a one tablet a day, the dosing that we are utilizing. So it's very important to also deal with those issues around how we are taking the medication. We do know that particularly the new regimens, they do assist us with making sure that patients are virally suppressed. Now, Lolly indicates that at the clinic, they told him that his viral load is high. So we certainly need to look at the adherence issues, but we could also look at other factors that could be making him, if he is absolutely compliant, we do adherence, what we call enhanced adherence counseling. And if he is indeed compliant, then we need to look at what is the cause of the viral load. Is it perhaps that he's going into viral load, what we call virological failure? That's the word I was trying to find. And in which case we will need to consider switching the regimens, but we have to make sure at the outset that the adherence issues are taken care of. And if he is, we also, if he is worried that he's getting sick, we also, we have to, part of the counseling is making sure that for his sexual partners, he is using condoms. And because we know that when you are taking treatment accordingly, we are preaching the message of U equals U, which means undetectable viral load results in the fact that you can't transmit, so it's untransmissible. So we really push some of those messages. So I think it does need for us to get the basics right before we can then start thinking about switching him into another regimen.
All right, Papa Lolo, I hope you will handle hore ba itseng ka taba e o ye clinic ba o check ba bone hore medication o enkang ke yona yo sebetselang na before ba o change ba o kenya ho eng. We've got an anonymous caller rather. Good day, anonymous. Seem to have lost anonymous, but I'm sure they'll call back a little bit later on. Doc, before we wrap things up on our end, I think an important one is asking the question of who's at risk of acquiring HIV and what do the different risks look like for different groups?
Yeah, I think that's an important question. Thank you so much. I think generally the general population is at risk, but we have people that we classify or what we call or target population groups that we call key populations or priority populations. We know, especially as we are reaching saturation and we are struggling to find, people, diagnosed, testing and treating. So we have to move away from the universal testing, but towards more targeted testing. So the people that are at the highest risk are men who have sex with men, gay men. We know also young women, and also people who inject drugs. So those are the people that, particularly some of our preventative modalities, which is PrEP, which is pre-exposure prophylaxis, we're actually targeting to those particular groups that are high risk, so that they can reduce their chance of then transmitting or getting the disease.
Well, thank you so much, Dr. Ntombifikile Mtshali, the Deputy CEO of the Aurum Institute South Africa. After the break, producer Wandile Mfugeng is standing by at the Fundisa Disability Center in Orange Farm. And of course, we'll speak to Gladys Pule, the technical specialist at Right to Care, about the challenges that people living with HIV face. Stay with us. Welcome back to Vital Signs. Now, we cross live to producer Wandile Mfukeng. He's standing by at the Fundisa Disability Center in Orange Farm, where the Johannesburg Health District is hosting a build-up towards the World AIDS Day commemorations happening tomorrow. Wandile, take it through.
Very good morning to you again, Dr. Mtombeni and the viewers. Indeed, we are still at the Orange Farm district. We are here to basically do a build-up towards World AIDS Day. So they are hosting an event to encourage people to know their status. Currently, there are a lot of people who are coming in to do their testing. And with me right now, speaking about testing, I have someone who already knows about her HIV status, and they are just about to share with us their experience and what they wish could be included within the HIV talks. We are currently joined by Mam Nandi Ngobo. Mam Nandi Ngobo, thank you so much for giving us your time. Could you just kindly talk to us about, as umuntu who is living positive, talk to us about ama challenges that you are facing?
Sanbonani, there's a lot of challenges, but the biggest challenge is it's discrimination, and it causes people not to be able to accept their status easily. So that challenge, it needs help to generate AMA support groups. So at this present moment, it's very difficult to generate AMA support groups because of that discrimination. Our families are not supporting us as much. Our friends, our community, there's still that stigma that goes with HIV. So it becomes a really a challenge. That is why we have so much defaulters. People are defaulting in their treatment because they haven't disclosed their status. So they find it difficult. If I tell someone, then everybody else knows my status.
When personally, how long have you been living with HIV, and how did you overcome those challenges, the stigma and disclosure? Was it easy for you or difficult for you to disclose to your family members or friends?
I've been living with HIV for 20 years now. It wasn't easy. It was very difficult at first. As you know, I'm coming from KZN. Some people died because of their HIV status. So it was difficult even for my family to accept me as a person who was HIV positive. But the biggest support that I got, it was from a support group. I got a support group which was very powerful, and they gave us information in that support group so that you know how to deal with other challenges. And you are able to see that you are not the only one who's living with this disease. So there are some people who have struggled, but they conquered. They're still alive today. I'm one of those people. So for 20 years.
Maybe just lastly, in under 30 seconds, your experience with medication. I know there are people who are defaulting, or rather those who are not taking medication. How has medication helped you throughout your journey?
For me, taking treatment was not easy at first, because if you remember a long time ago, the treatment had so many side effects. So luckily now, the treatment that we have now, it has less side effects. So people shouldn't be afraid to take treatment. But the biggest support is to disclose your status. Then it becomes easier for you to take your treatment. So I have my family support, my children, they are my biggest support.
Thank you so much. That was Mam Nandi talking to us about her experience with living with HIV and the importance of continuing with your treatment, or rather also being part of any support group that you can get that will help you within your HIV journey. For now, that is back to you in studio.
Thank you very much, Wandile. Now, with 5.7 million citizens infected with HIV, South Africa has one of the highest numbers of infected adults and children in the world. Many people living with HIV or at risk of HIV infection do not have access to prevention, treatment, and care, and there's still no cure for HIV. Now, with these difficult and different levels, of course, of other issues as well, such as stigma that the people deal with, and people living with HIV can sometimes experience heightened levels of emotional and psychological issues, including fear, guilt, abandonment, lack of worth, as well as harassment. Now, to give us a bit of perspective about some of these challenges that people living with HIV face, we're joined by technical specialist at Right to Care, and that is Gladys Pule. Thank you so much for joining us today.
Thank you so much for having me.
Good. Before we continue on our basics course of HIV and AIDS today, which I think is important because sometimes we need that refresher to remind us of the basics, let's talk about Right to Care. What's Right to Care and what do they do?
Right to Care, we are the biggest NGO in South Africa. We are actually not in South Africa alone, we're in other countries as well, Lesotho, Namibia, and we are in Malawi as well, and Zambia. Sure. We are able to actually reach quite a large number of communities out there, and we're not only treating HIV AIDS as seriously, we also treat health seriously because we have moved in actually making sure that we are innovative, and when the issues like COVID comes up, we are there as well, and we are providing all the expertise that we have as an organization.
Now, a lot of people have this idea of HIV and AIDS being in the small low bracket that it belongs to and no other things really can be discussed around it. Are we doing things right with respect to HIV? And if we aren't, what are we doing wrong?
I think we are doing things right, and we've reached quite a lot of people. Yes, there are quite a few things that still need to be worked on, but the amount of work that has been done really deserves to be commended because of the work of different NGOs, the Department of Health, that are reaching out there to make sure that people get the services that they require in different healthcare facilities. Obviously, it comes with its own challenges.
Now, you speak of having this role as an NGO. But a lot of people would speak to, belonging to a government, that the government should take care of its people and test the people and make sure that they've got all the access to medication and things such as that. And naturally, this has proven to be something that's quite difficult, and that's where the role of NGOs has come in to assist and help out there. Do you think collaboratively enough is being done to address the issue of HIV/AIDS? In the historic sense, but also in the future sense with respect to us making sure that we're preventing, making sure that the numbers of people that are getting infected is lower, making sure that adherence is something that we look at, and treatment and things such as that?
Like you rightfully say, that Department of Health alone was not able really to reach the number of people that got themselves infected with HIV. So as a result, all the NPOs and the available stakeholders around the area had to come out, and the funders who actually support these NPOs with the money to be able to render the services. So we find that as NPO and as Right to Care specifically, we are able to increase the number of healthcare workers in Department of Health facilities. Because as Right to Care, we don't have facilities and we don't have patients. They all belong to the government. They all belong to Department of Health. But then we come in making sure that there is enough staff members to actually render the service. We also make sure that there is enough medication available for those clients that need medication. We also make sure that there is a mentorship that goes on a day-to-day basis, because as new developments in HIV come up, we need to make sure that we educate the very healthcare worker in actually making sure that they render the service as expected of them. So a lot is being done, and the future is actually looking bright, because looking at the number of people that have been placed on ARVs as well, looking at PrEP that has been included in the management of HIV and AIDS, it tells you that all of those programs are gearing towards making sure that we end this kind of challenge that we're facing in HIV.
Now, you speak to this idea of, equipping ourselves with all these things that we've got in terms of a policy that exists, saying that PrEP will be available, saying that, the clinic should test, saying that, you can go to this facility and get this sort of treatment and things such as that. Is that the reality on the ground? Are we finding that people are finding it easy to get tested, are finding it easy to get access to medication and things such as that to support a diagnosis of either negative or positive?
The challenge that HIV and AIDS people face, that are infected with HIV and AIDS face out there, is the availability of healthcare facilities in the vicinity where they stayed. And where these healthcare facilities are available, the accessibility becomes an issue, because they need to spend a lot of money to get to those facilities. And as well, even if they do have some money to get to the facility, them accepting the kind of a facility that they are into, the standard in other areas is not of good standard. And also the good quality services that are being provided in those facilities still becomes a challenge. And obviously we also struggle with the healthcare attitude toward people that actually have HIV and AIDS. So these are some of the struggles. But the main struggle that we have picked up is a struggle about people getting enough supply of medication on a month-to-month basis. They're still getting 1 month supply. In other areas, they get 2 months supply, which pushes them to keep going back to the facilities, even if they are well and there's no need for them to actually go back to facilities. And now it exposes them to a larger queues that actually have to wait there. So the waiting times becomes a bit of a challenge as well. So which actually makes adherence to medication to be a bit of an issue. So these are some of the challenges that we face in assessing the healthcare in different facilities.
Okay, lovely. We've got Anonymous on the line. Anonymous, good day. Anonymous?
Good day.
Hi, how are you?
I'm good, thanks. How are you?
Very well, thank you. What's your question or comment today?
I just wanted to comment about the medication because I used to take my medication at night.
Yes.
Now I'm switched. I have to take it in the morning. And ever since, it's been about 3 months now, I've been taking in the morning. And I realized that my throat started to, I'm not able to swallow pills anymore, which means sometimes the last time I took the pill, it stuck to my throat. And I thought maybe it's just a thing, maybe I have a swollen throat or something. I bought the lozenges for the throat. I took them and then, but this is being ongoing.
It's been ongoing.
I cut the pill in half, but it's still stuck to my throat. I think it's because of the change of taking the medication in the morning, and because the pills is also too big. So I want to ask, is it possible if I can crush the pill and drink it, the powder? Is it safe?
I hear what you're saying, and I'll answer that question for you now. The question is, why were you switched from taking your medication at night to the day? Did they change your medication altogether?
Yeah, they give us different pills with different names, but they say still the same. But the one they gave me 3 months back, they said it's for the morning, not to be taken at night.
And
so
then
I had to switch.
And the medication you take for the HIV, is it 1 tablet a day that you're taking for that?
It's a tablet a day.
Okay, right. So for that tablet there, generally, these are the ones that might have film coating on them and things such as that. Generally, with any medication, you want to take it as a whole. You don't want to be crushing tablets and things such as that because the distribution of the active parts of the medication might be in different areas of the tablet. So maybe don't break tablets or do things such as that. But importantly, which might not be part of your HIV medication, is tablets that have a capsule that can actually come out and there's powder inside. Those should not be broken up. Those have an actual coating for a reason so that it only gets digested what's in the stomach and then gets absorbed there. So very importantly, what you might have is a concurrent other problem, which means that, you know, you've got a throat infection, you might have a tonsillitis, whatever else that's currently going on there. You need to go get seen for that specifically because I don't think it should contribute to the medication that you're taking, and I don't think your medication is causing you to have a sore throat. So please, Anonymous, go to your local clinic, go be seen at the local clinic, get an assessment done so that they can see and raise all these questions with the nurses or the doctors that are currently seeing you to say that, you know, you used to take your medication at this time, now you've been switched to taking it this time. Tell them about what's going on in your life as well. Because sometimes we tell people to take their medication at night, but you find that they are shift workers and work at night. So it becomes problematic for them to take the medication because medication can have side effects. So let's be very, very, very open when we speak to our doctors and nurses so that we can give them all this information and they're able to make the right decisions for ourselves so that we can follow that information as well. Well, thank you so much, Gladys, for joining us today and giving us information on Right to Care. That's Gladys Pula, the technical specialist at Right to Care. After the break, we'll speak to Dr. Tato, the director for HIV Prevention Strategies at the National Department of Health, about South Africa's HIV Prevention Strategies. And we'll also speak to Zolelwa Sifumba, the TB-proof MDR-TB survivor and activist, about World AIDS Day event that will be hosted tomorrow at the Desmond Tutu Hall in Khayelitsha, Cape Town. Stay with us. Welcome back to Vital Signs. The inequities, of course, that perpetuate the HIV and AIDS pandemic can and must be overcome. We can end AIDS if we equalize. That means more financial resources, quality, suitable, and available services for HIV treatment, testing, and prevention. Better laws, policies, and practices to tackle the stigma and exclusion faced by people living with HIV, especially marginalized population. Now, everyone needs to respect and, of course, be respected. And right now, we'll welcome our our guest, and that is Dr. Tato Chidarikire, the HIV director, or rather the director of HIV and STI Prevention Strategies at the National Department of Health, to speak to us about South Africa's plan to end AIDS by 2030. Thank you so much for joining us, Doc.
Good morning, and good morning to the listeners. Thank you for inviting me.
Now, today we are having somewhat of a beginner's basics course on HIV in South Africa. And I'd like for you to potentially take us through a short historic encounter of the epidemic as we've experienced it in South Africa.
Right. So in South Africa, as in most countries, we received our first, I think, I would say case, for lack of a better word, of HIV in the early 80s. And we have moved. At the time, we didn't really know much, as the world really didn't know much about what was happening. And then if I fast forward to the 90s, when now there was a lot more information, even though there was no treatment. And listeners and yourself would remember that at the time, we also did not have treatment for HIV. However, we actually did have tests. We were actually using an ELISA, which one would go, take blood, wait for a few weeks, and then come back to a clinic or a hospital to get their results. Over to 1999, South Africa then had in government what we used to call VCT at the time, which was voluntary counseling and testing. It was adopted as a government program. And then we moved from doing a ELISA test to doing rapid tests. Listeners would be kind of like aware of this one, because this is the one that we're doing now, where you do a finger prick, you get your results in 15 minutes. And then fast tracking again to the early 2000s, we started having our treatment. We started putting mothers on treatment to prevent transmission to the babies. At the time, we had like one pill, we had Nevirapine, and one would take it just when they get into labor. But it was very good in terms of really preventing the transmission to the child. And again, moving forward, we started then revising our policies as we started procuring the treatment within our domestic funding. And South Africa, I think, is one of the countries that really responds to the HIV response domestically in terms of financing. And then we started moving with treatment. We started giving people treatment at a CD4 count of 200. Then we moved to 350, then to 500. And a few years ago, we then started test and treat. So right now, if one tests HIV positive, they can actually get treatment immediately or as soon as possible when they're ready. And our testing now is actually, in terms of case finding, has moved beyond clinics. We test in communities, we test basically everywhere. And we're actually now providing HIV self-tests, which we call self-screening test in South Africa. And one can get a test, go test themselves in the comfort of their own space, but still go back to a facility if they screen reactive. I think that's our program in a nutshell.
I think you've summarized it quite nicely, but let's look at the current situation we find ourselves in. What do the numbers look like for those that are positive in terms of the tests that were received that are currently in South Africa? And of course, of those, how many are on treatment?
So South Africa has an estimated 7.9 million people living with HIV currently. And those who are on treatment is just over 5.7 million. We do have the highest number of people living with HIV in a country globally, but we also have the highest or the largest treatment program.
No, those numbers are good to hear in the breath or in the thought process where we look at what we'd look to or like to achieve with respect to the programs that you've highlighted. And programs and policies are always great to have, but we obviously have to have a deadline with respect to when we'd like to achieve these things. What is a deadline and what kind of objectives are you looking to achieve? What do we have in terms of a utopia? In an ideal world, what would we have as South Africa?
So maybe one would be aware that globally, the world is moving towards 2030 goals, and the 2030 UN AIDS goals are to have AIDS as no longer a health threat. So unfortunately, we still have infections, but we want to make sure that AIDS is no longer a health threat. Ideally, we wouldn't want to have infections at all. We would like to close the tap. But South Africa committed to what we now call the 95-95-95 targets of UNAIDS, aligning to the new global AIDS strategy to end AIDS as a public health threat by 2030. So these targets are saying that by 2025, 95% of people who are HIV positive should know their status. You'd remember that I said we have an estimated 7.9 million, and if we're working on that, just simple arithmetic, 95% of that comes to about 7.5, maybe 7.6 million. So at the moment, we are just around 7.4, which is about 94%. And then the second 95 then says that 95% of those who are diagnosed positive should be on treatment. And there we are at about 74%. Our 5.7 million is 74% of the 95. And then the third 95 says 95% of those on treatment should be virally suppressed. The whole aim of being on treatment is to be virally suppressed, because if the viral load is undetectable, then it means the chances of transmission are extremely minimal. So we do have the 5-year target of the Global AIDS Strategy, but we also have our National Strategic Plan, which is the country's response to HIV and TB and STIs. Our current plan is actually ending now in 2022, and we are embarking on the 5th generation NSP, which should take us to the 2030. But it will be 2023 to 2028. And as I say, that it really is supposed to guide us towards achieving the 2030 goals of having AIDS as no longer a health threat in the country.
Now, let's look at the risks or the groups that are at risk of acquiring HIV at this point in time. What strategies are we coming up with to make sure that those numbers don't find themselves increasing?
Right. So, with the current National Strategic Plan, which is now kind of like ending as we revise, we talk about Objective 3 of the NSP, of the current NSP, talks about leaving no one behind. This basically means that every single individual who is at risk of HIV should actually be offered the services, be able to get tested without prejudice or judgment, should be able to be put on treatment if they are test positive, and then be supported to be virally suppressed. So while South Africa has what we call a generalized epidemic, I mean, we're at about 13% in terms of the general population, and then the 15 to 49, we're at about 19%. But what I want to try and say now is our populations that are at higher risk, we refer to them as key populations. So within our generalized epidemic, we also have pockets of populations that are at a much higher risk. And here we're talking about, our sex workers, our MSM, young people, maybe not necessarily key per se, but vulnerable adolescents, girls and young women who are at a much higher, risk of acquisition and or transmission as compared to their male counterparts. So we try to have targeted services to these populations. Key populations, for example, we know that there are usually challenges in terms of them getting into facilities due to a lot of different issues, be it social or structural, or even just judgment and attitudes. So we try to move services into the people, into communities. I think it's good to point out that we are all moving towards self-care at the end of it all, where people should really be able to manage themselves and be able to only go to a clinic or to see a physician or a clinician when they need to or when they get sick. So we want to try and use a strategy called differentiated service model. In South Africa, we call it differentiated model of care, DMOC, where we bring the services to individuals in terms of case finding. As I said, we use self-testing. We also try to do what we call index testing, where an individual who tests positive can then be followed in terms of their social and sexual network. And then we can try and test their partners, including their children, if it's a mother. Because, we do have mother-to-child transmission. And then their partners, of course, it makes better sense. It may be a high-hanging fruit, for lack of a better phrase, but we are now moving towards that last mile of case finding. Remember, I said we're at 94%. We really need to ensure that we get all our key and vulnerable populations into the systems. For young people, we have embarked on what we call youth zones, which are spaces and time in a facility where young people are seen by a young nurse like themselves. We always have all these challenges of young people and older persons in terms of the nurses, the aunties and the mothers' friends. So we want to make sure that they are seen by nurses that are more or less their age, who understand what they're going through and are trained to provide youth-friendly services. And we don't want to leave the boy child behind, because young people don't infect themselves. However, we also want to make sure that we go to the older men. We provide services like voluntary medical circumcision,
yes,
men's health interventions. We have pre-exposure prophylaxis, which is a pill, and this is very important. Pre-exposure prophylaxis is a pill, is an ARV that is given to HIV negative individuals. So if one goes into a facility and they are offered a PrEP, they shouldn't be alarmed that I'm giving ARVs when I'm negative, because this particular ARV is supposed to keep one negative.
Dr. Tato, I'm going to have to jump in there. Unfortunately, we ran out of time, but I was just waiting for that very, very important point, and that's highlighting the idea of PrEP, this pill that you would take that prevents you from acquiring HIV, which I think the vulnerable groups and the groups that are at risk need to be very aware of. Thank you so much for joining us today and answering all of our questions and highlighting the National Department of Health's plan with respect to the policies and the ideas that they have in terms of goals that they want to reach before 2030. Now, this is World AIDS Day, and of course, UNAIDS is urging each of us to address inequalities which are holding us back from progress in ending HIV and AIDS. Dr. Zolelwa Sifumba, together with TB Proof and other organizations, are hosting World AIDS Day event at the Desmond Tutu Hall in Khayelitsha, Cape Town. Now, the aim of their event is to address stigma that's been shown that can, of course, have negative effects on the cascade of HIV and AIDS and, of course, TB. Dr. Sifumba joins us live to talk to us about the event. Thank you so much for joining us, Dr. Sifumba.
Hi, hello to you all and all the listeners. Thank you for having me today.
Right, so let's talk about the event that will be happening tomorrow. What makes it such an important event and who can come?
So what makes it such an important event? I'm sure everybody's asking themselves why somebody from a TB organization is taking part in World AIDS Day. And the reason we're doing that is because you can't talk about HIV without talking about TB, as well as vice versa. So the reason is both of these diseases are prolific killers, and both of these diseases have a huge amount of stigma attached to it. So I faced stigma when I had TB treatment. So it is also something that is faced by millions of people around the world that causes delays in recognizing symptoms, going to the clinic. And this stigma occurs at home, at workplaces. It occurs at the hospitals that people are visiting. So the reason why this event, why I'm inviting everyone is allowed to come, is because we will be hosting talks on stigma. We will be talking about what stigma is and how it affects people. We'll also have some HIV and TB information. There will be stalls for HIV testing and TB screening. We'll also be playing some indigenous games and a lot of, entertainment for adults and kids. And we will have a Q&A session at the end. So yes, it promises to be a great session of actually getting people to understand what stigma is. We as TB Proof actually did a study in Khayelitsha about stigma, and actually now this is us giving the information back to the people. And basically, I want to urge everyone who takes part in World AIDS Day, I want to urge our National Department of Health that you guys need to be focusing on stigma. And we as TB Proof would be happy, to collaborate on that work. But it needs to happen, because these are people we are talking about, and issues of stigma can affect how people access services. They can affect whether people disclose to the people around them in their lives.
Thank you, Dr. Sifumba. Sorry, I have to jump in there. We're out of time, but I think you've really highlighted the importance of your event tomorrow, and that's, of course, looking at stigma, the stigma that comes with HIV, AIDS, as well as TB, and how all these things intermingle with each other, as Dr. Sifumba. And if you're in Khayelitsha tomorrow, head on over to the Desmond Tutu Center, and they'll be able to give you all kinds of information if you're looking for that kind of information. From us here on the Vital Signs team, thank you so much for joining us. It's been really great. Please go out and remember the importance of HIV and AIDS prevention. And of course, go on treatment if you are HIV positive. And if you are HIV positive or know someone that might be, encourage people to go out and get tested as well. Thank you for joining us. We'll see you again soon.